of the Stridor, and after that, we could not get the connection. So let us continue from where we left off. We had, if I'm not mistaken, I had discussed the. I'll give a brief recap before we go into the today's topics. So yesterday we had discussed the importance of hypoxic brain injury. Why is it important to worry about Stridor? Why Stridor is such a big problem? Why you should take care of the patient who is having Stridor? Why you should immediately take care of the airway? Why you should immediately relieve the obstruction if you can in a patient with Stridor, for example, in a foreign body. So we had discussed the consequences of hypoxic brain injury, and only brain can stand only 7 minutes of lack of oxygen, after which the brain cell starts dying, and then there is a lot of problems. Adults and children, they have two different presentations of hypoxia. In children, the first sign may be a bradycardia and cyanosis and vasoconstriction. So in infants, the first sign of hypoxia is bradycardia. The heart rate will decrease. So you please remember this. Any child who is stridorous, who is having Stridor and showing signs of bradycardia, you need to think about patient's brain is undergoing hypoxia. So I had also told about Poisson's law, which says that the work of breathing is proportional to the fourth power of radius. And I had compared the airway between adult and children. The main thing is that the cartilages are very pliable in children. Cartilages are very pliable in children, and the infants are obligate nasal breathers until 6 months of age, and they have a very large cranium in proportionate to their body, and the larynx is at a much higher level than adults. So the meaning of the word Stridor means stridere, which means harsh, grating noise. The definition of Stridor is uh, continuous musical monophonic sound produced due to obstruction at the level of the glottis, the supraglottis, or the subglottis. And the Stridor is classified as inspiratory and expiratory and biphasic. And how do you clinically go about assessing the patient with a Stridor? I had also talked about laryngospasm, and I had also talked about post-obstructive pulmonary edema. As ENT surgeons and people who deal with obstructive sleep apnea, you should be sensitive about the condition called post-obstructive pulmonary edema, because it's a very dangerous condition. Unrecognized can lead to death of the patient. And I had also talked a little bit about mitomycin C, which is a scar inhibitors frequently used in endolaryngeal surgeries to prevent scar formation in the larynx. And I had also talked about foreign body aspiration, radiopaque foreign bodies, presentation of hyperinflation in the lungs, and bronchoscopy. I talked about kerosene lung syndrome. I talked about laryngomalacia, which is a benign condition, and I showed pictures of laryngomalacia. This is all just a revision for you. These are all completed last time. Around 30th slide, I think the connection just got knocked off. And I had also talked about paradoxical vocal cord dysfunction, what is called inducible laryngeal obstruction, a new condition that has been described in the new books. You will not find them in the old books. It's not a classical condition. Here there is a paradoxical vocal cord adduction, and there is Stridor, and things like exercise, they trigger this kind of paradoxical movement. And the important differential diagnosis is bronchial asthma, which also is triggered by exercise. And I had I think this is somewhere around this slide the connection had got knocked off. So we'll continue from here. If I'm not mistaken, this is where I had left off, right? So we'll continue from here. So recurrent respiratory papillomatosis. So there are many names for this. One is called respiratory papilloma. The second is called recurrent respiratory papillomatosis. The new name for is called juvenile onset respiratory papillomatosis. Why it is called juvenile onset? Because it's not found in childhood. When the child becomes 10 or 12 years of age, only it starts manifesting. That's why it's called juvenile onset respiratory papillomatosis. So it is caused by double-stranded DNA virus, human papilloma virus 6 and 11. And how it is acquired? So basically, when the child is passing through the maternal cervix, mother's cervix has a lot of condyloma acuminatum, and this condyloma acuminatum gets access to the larynx. And when the child becomes 10 year or 12 year of age, it starts growing. So that's why it's called juvenile onset. And there's no curative treatment. And the only treatment is you just knock off all the respiratory papillomatosis. And last time I had told that it is a condition where you cannot go this way, you cannot go that way. Why? You cannot do tracheostomy to relieve the airway, even though the patient is in Stridor, because once you do tracheostomy, the virus will start spreading into the tracheostoma and will grow into the tracheostoma, and it will block the tracheostoma. So tracheostomy is not very advisable in this condition. And at the same time, you cannot let the child suffer with stridor and airway obstruction also. So it's a very difficult condition to treat, and the book says that there's literally no curative treatment. And what you do basically do is you can use the laser to knock it off. And then also you have to be very careful while you're doing a laser therapy with this, because the problem is that the fumes it produces while doing laserization, that fumes itself, if the ENT surgeon or somebody inhales it, they will start getting this laryngeal papillomatosis in their larynx. So it's such a problematic condition, very problematic condition to treat, very problematic condition. So this is what a JORP looks like, juvenile onset respiratory papillomatosis looks like. So you can see almost the papillomatosis or the papillomas have obliterated the airway. It is endotracheal tube going in between. So this is a severe form of JORP, juvenile onset respiratory papillomatosis. Treatment is you basically laserize it, and then you apply cidofovir so that it doesn't recur back. Okay, so treatment is laserization with cidofovir, and there are some new treatments that are available. This is exactly where the connection had gone off. What happens is that there are some new treatments available. There is 585 nanometer pulsed dye laser is available, and 532 pulsed KTP laser, potassium trianom phosphate laser, is now available in the market. Recent treatments for JRP. वही मैं ask पुराना laser से करे नया laser से करे क्या फर्क पड़ता है? The फर्क पड़ता है because this laser is absorbed by the hemoglobin, so it is very effective in releasing the vascularity of the tumor, hence lesser chance of recurrence. So response rate is better, like that they are telling. Okay, so फर्क पड़ता है. So one more second thing is that you can apply cidofovir. Cidofovir is a cytosine nucleotide analog. It suppresses DNA replication, but the problem with cidofovir is that it has got an oncogenic potential. Okay, cidofovir itself will cause malignancy. ऐसे ही cidofovir नहीं लगा सकते because that itself will cause malignancy if used in excess, and patients are undergoing surgery again and again. So the chance of the papilloma turning malignancy increases when you apply cidofovir. Per se, by itself, juvenile onset respiratory papillomatosis does not turn into malignancy. A favorite and a favorite question of senior examiners: if you're talking about JRP, will it turn malignant? The answer is it rarely turns into malignancy. Reason being is that the papillomas are caused by human papillomavirus 16 and 18, which cause condyloma acuminatum and don't cause malignancy usually. And there is hope for permanent prevention in future because there is quadrivalent HPV vaccine that is now available, which protects against 6, 11, 16, and 18 serotypes. So by vaccination, we may be able to prevent this condition from happening. So this is what picture looks like of JORP looks like. So last time we had just talked about afebrile stridor. Now another important topic, absolutely important topic, is subglottic stenosis. Very frequently asked question in the examination, very frequently asked question in your viva, very favorite question of the examiners. Interviews everywhere you will be asked about subglottic stenosis. It's a favorite question. So subglottic stenosis is stenosis at the level of the subglottic region, below the level of the vocal cords, at the level of the cricoid cartilage. And why cricoid is the cartilage that usually undergoes stenosis, that everybody knows, the UG question, is that the cricoid is the only ring in the respiratory tree, right? Cricoid is the only ring in the respiratory tree. So that's why it's a full circle, right? 360-degree circle, and other cartilages are only C-shaped. Posteriorly, there is only ligament. So even if there is stenosis, completely it will not block the airway. So subglottic stenosis, ring cartilage, cricos means a ring. So ring-like cartilage, completely there is cartilage on all four sides. So any obstruction, immediately there will be stenosis. Complete cartilage, cricoid cartilage, subglottic stenosis. Subglottic stenosis can be congenital, it can be acquired. Subglottic stenosis is defined as subglottic lumen less than 4 millimeters in size. So as a postgraduate student, undergraduate student, there is subglottic stenosis, cricoid bolega, it's enough. For you, you should know the correct definition. The correct technical definition of subglottic stenosis is a lumen, a subglottic lumen, which is less than 4 millimeters in size. Please remember this: 4 millimeters in size and less, subglottic stenosis. Subglottic stenosis 4 millimeters. Okay. So what are the causes of acquired subglottic stenosis? Prolonged intubation. Number one cause of subglottic stenosis: prolonged intubation. Putting an endotracheal tube for a very long period of time for both adults and children will lead to subglottic stenosis. Using a cuffed endotracheal tube in a child, you are never supposed to use cuffed endotracheal tube in a child. Child must always have uncuffed tubes. The air must flow freely through and in and around the tubes. It's okay. There's no need to form a thick seal, right, by putting a cuff. So children, you should never use cuffed endotracheal tube. If you end up using a cuffed tube, you will cause subglottic stenosis, right? And even if the cuff is used, it has to be frequently deflated, time has to be given, then it has to be reinflated. So cuff has to be periodically deflated every 2 hours or so for 10 minutes, and then it has to be reinflated. This is expert nursing care that has to be given in all patients who have a cuffed endotracheal tube. If you forget to write this instruction, the nurse, this has happened with people before. The doctor has forgotten to give the instruction. They have put a cuffed tube and they've forgotten about it. बोला ही नहीं उसको, तो उसको मालूम नहीं. She doesn't know about it. You have to instruct it very carefully. The ENT doctor or the anesthetist has to tell the sister to periodically deflate the cuff, because if you don't deflate the cuff, what will happen? The continuous pressure from the cuff will put pressure necrosis around the subglottic region and will predispose to subglottic stenosis. Number one cause of subglottic stenosis, prolonged intubation. And after corona, we are seeing more number of patients, because during the corona time, so many people who are intubated, so many patients were under intubation, and many of them developed subglottic stenosis. This is purely because the subglottic stenosis, because that the pressure cuff was too much, right? So you should not overinflate the cuff. That is also one of the reasons why you get subglottic stenosis. You should not overinflate it. If you overinflate it, naturally chances of necrosis and pressure necrosis are more, right? So prolonged intubation is probably the number one cause of subglottic stenosis in the community. Second causes could be related with gastroesophageal reflux and eosinophilic esophagitis, right? These are three conditions that are linked with subglottic stenosis. And very, very important, I think you should know this by heart, is Mayer and Cotton grading system. Mayer and Cotton grading system. It's an internationally accepted standard grading system of subglottic stenosis. And if I feel that even Mayer and Cotton grading system itself can come as a question for you in your final DNB examination, final examinations, or even foreign examinations, right? Mayer and Cotton grading system itself can come as a question, because it's so important, right? Subglottic stenosis and Mayer and Cotton grading system. So once your mind gets to subglottic stenosis, immediately you should think in terms of Mayer and Cotton grading system. I'm going to explain that next, because it's so important. And then patient with minimal subglottic stenosis, how they will present? They will not have stridor. They will have compromised airway, but they will never have stridor. Only when these children or adults, when they go for respiratory infections, they will start developing the stridor. So they will develop stridor only when they go for respiratory infections. So the recurrent respiratory infections will present with stridor. Otherwise, the child will have a normal airway, and the patient may be asymptomatic for weeks and months. The patient may not have any symptoms. They might have got out of ICU and they may be asymptomatic for many months. And suddenly, when there is a cold or when there is a fever or when there is a respiratory tract infection, they will develop stridor. They will come to ENT, and we have asked them, yeah, have you undergone intubation or something? And they say, I was in ICU 6 months back for 2 months and I was intubated. Like that they will tell. So this is a typical history. That this sort of patients also we have seen. I have personally seen a lady. So she was intubated and kept for 2 months, and then she became all right. She was going home. She was living happily her life, and it was going on for a few months. One fine winter morning, usually this all happens in winter time because respiratory infections are common in winter, right? So winter month, she got fever and she got respiratory tract infection, and she had severe stridor. And they said all of a sudden she's developed a stridor, and they brought the patient to me. Naturally, I made a diagnosis of subglottic stenosis. Ending on. So this is what Mayer and Cotton grading system of laryngeal stenosis or subglottic stenosis is. Please remember this. You have to remember as a postgraduate in ENT, you should know this classification system. There is no excuse, and it's very simple. Grade 1 is up to 50%. Grade 2 is up to 70%. Grade 3 is up to 100%. That is 99%. Grade 4 is nothing. There is no lumen at all. So very easy to remember. Grade 1 is 50%. Grade 2 is 70%. Grade 3 is 99%. Almost everything is completely obscured in grade 2. Very pinhole may be there in grade 3. And then grade 4 is no detectable lumen. Very easy, just 4 lines. 50, 70, pinhole and no lumen. Right? 50, 70, pinhole and no lumen. 50, 70, pinhole, no lumen. So remember this, please remember this. Very easy to remember. 50, 70, pinhole, no lumen. Okay, so Mayer and Cotton grading system. Okay, so this is a picture of a subglottic stenosis. This is the pictures are there for you to remember. See how small, almost 70% is gone. This is almost grade 3. If you remember, grade 3 is 50, 70, almost 70% is gone, but still there is a lot of airway is there. So this is, if you remember the Mayer and Cotton, 50, 70 pinhole, right? 50, 70 pinhole. So this is grade 2, 70, right? Almost 70%. This is, you can say, grade 2. So what is this? This is arytenoid granulation tissue following intubation. So this can also follow intubation like subglottic stenosis. There can be granulation tissue on the arytenoid cartilages, and the patient can present with stridor after intubation. So this is another consequence of prolonged intubation, arytenoid granulation. Fortunately, it's much easier to treat. You can use laser and you can vaporize it and you can apply cidofovir. Okay. laryngeal stenosis. You can see the anterior commissure is also blocked off, posterior commissure is also blocked off, complete laryngeal stenosis. Okay, now I'll tell you a little bit about the congenital subglottic stenosis. Congenital subglottic stenosis, as you can see in this X-ray, you can see the airway is getting narrowed off like a thin line, right? What's called steeplechase sign, cause steeplechase sign, steeple sign, or what does that mean actually? So if you look at the top of a church, if you look at the top of the church, you will find that there is a thin, it looks like a thin, what do you say, but thin triangle-like thing, right? Like a tip of a lancet, right? So that is called the steeple of the church, right? The tip of the church top. It looks like narrowing, looks like the tip of the church top. So that's what it looks like. So that is your congenital subglottic stenosis. You can see the narrowing in the subglottic region and narrowing in the subglottic region and this kind of subglottic stenosis is common in Down syndrome. It's common in Down syndrome, and patients most of the time they have self-resolution. And if you take an X-ray AP view, you can see the narrowing just like the top spire of a church. You can see the narrowing here. It is pointed out by the arrows, right? So the narrowing you can see in the subglottic region. So this is congenital subglottic stenosis. So how do you treat? Now the treatment itself is a very big topic. There is a book itself on treatment of subglottic stenosis. So I have just given all the gist of treatment in a single slide so that you can know. So basically what you do is you split the cricoid, because it's full ring, right? So you have to decompress the cricoid by making an anterior split, and then you apply something to keep it open. Otherwise, if you just split it and leave it, it will join back. It will join back and undergo fibrosis. In fact, the fibrosis will be far worse if you don't do anything to keep it in place. The fibrosis will be far worse than before, right? So पहले से भी ज़्यादा हो जाएगा because you already injury की वजह से this has happened. Circumferential necrosis की वजह से हुआ है. So if you split the cricoid and leave it, the subglottic stenosis will get worse. So you have to interpose something, you have to put something in between. That is the principle of subglottic stenosis treatment. Okay. So please remember the treatment strategy. If you just cut it out, it will not solve the problem. So you have to leave something to stent it open. So how do you stent it open, right? टेंट के जैसे उसको खोल के रखने के लिए कुछ तो डालना पड़ेगा बीच में. तो क्या डाल सकते हैं हम? रिब का कार्टिलेज डाल सकते हैं, इलिया क्रस्ट डाल सकते हैं, कुछ तो डाल के उसको खोल के रखना पड़ेगा, वरना क्या हो जाएगा, फिर से फाइब्रोस होके जाम. Right? So one of the treatment is anterior cricoid split. Actually anterior भी काट सकते हैं, posterior भी काट सकते हैं. So you can cut it anteriorly, you can cut it posteriorly. No matter what cutting you do, wherever way you cut, you have to do something to split it open. So anterior cricoid split, what's called anterior cricotracheal decompression with mitomycin C application. So this is another, I told you, mitomycin C, you apply it so that it doesn't cause scarring, it reduces the scarring. So you cut it, you cut the anterior cricoid and you apply mitomycin C, and then you can do posterior cutting also, what's called posterior laryngotracheal decompression with mitomycin C application. So remember, anterior bhi kar sakte, posterior bhi kar sakte. And mild stenosis you can treat with balloon dilatation, and you can use laser endoscopy, and then laser endoscopy and you can apply mitomycin. You can use powered microdebrider, endolaryngeal microdebrider to debride it off, new instrument. You can use and you can do reconstruction using costal cartilage grafts. Basically, you take a graft and you interpose it in the split you have made, so that it doesn't get joined back and causes stenosis again. So splint it open, right? खोल के रखने के लिए कुछ तो बीच में देना पड़ेगा, and you can use costal cartilage, you can use ribs. Okay, so you split the lamina of the cricoid cartilage and you put some cartilage in between. That's called laryngotracheal reconstruction. Laryngotracheal reconstruction. This surgery is called laryngotracheal reconstruction. I hope I have explained it clearly to you. This is the principle of laryngotracheal reconstruction. तो क्रिकॉइड को एंटीरियरली काट दो, उसको खोल दो, और तो खुले हुए फ्रैगमेंट्स को होल्ड करने के लिए कुछ ना कुछ उसमें डाल दो. क्या डालोगे? कॉस्टल कार्टिलेज, रिब कार्टिलेज, कुछ भी डाल सकते हो, लेकिन कुछ तो डालना पड़ेगा. ऐसे ही काट के छोड़ दोगे तो क्या होगा? फिर से जान हो जाएगा. So this is the principle of laryngotracheal reconstruction. So this is laryngotracheal reconstruction. I think as for a postgraduate even this is more than enough. If you write in the examination what I have, right, along with drawing a picture of a cricoid cartilage and how the split is made, I think this is more than enough even for a long question. Okay. So one more operation that you can do is you can just cut the whole cricoid out. You can knock off the cricoid itself. काट के निकाल के, you can anastomose the trachea with the lower part of the larynx. What's called criciotracheal resection. So criciotracheal resection, trachea तक जो stenotic segment को काट के बाहर निकाल देने का. Another important thing is that these patients usually will have a lower grade tracheal infection because of subglottic stenosis, especially with methicillin resistant Staphylococcus aureus and Pseudomonas. I mean, this is a cause of concern, and they also have gastroesophageal reflux. So this is what I told you. I was telling this all along, laryngotracheal reconstruction. So this is the principle. Okay, this schematic diagram. You cut the cricoid cartilage and you put a cartilage graft in between to hold the stent it open. So this is actual picture of a endolaryngeal picture of a child who has undergone a laryngotracheal reconstruction in the posterior laryngotracheal reconstruction. कुछ नहीं है, anterior lamina काटा तो anterior, posterior lamina काटा तो posterior. So posterior lamina काट के anterior cricoid cartilage में वो graft लगाया हुआ है. You can see the white part is the graft, and that graft is holding in place, is stenting it open, stenting the airway open. So that concludes my part on subglottic stenosis. Now let's talk a little bit about laryngeal webs. Laryngeal webs are congenital or acquired. They are classified as thin webs or thick webs, and they are classified as anterior webs and posterior webs. Most of the time it is the anterior web between the anterior commissure, that is vocal cords ke beech mein. And the laryngeal web, if the child is having a congenital laryngeal web, you have to look for velocardiofacial syndrome. That is, you have to look for velocardiofacial syndrome. The child will present with biphasic stridor because it's a glottic problem, and while crying or feeding, you have, if the web is very thick, so the treatment is, if the web is very thin, you laserize the web with application of Stridor. Okay, you laserize the web, you laserize the web and you apply mitomycin C. It's not Stridor. Stridor is for HPV, mitomycin C. You apply mitomycin C and you laserize the web and apply mitomycin C. Thick web, what you do is you have to cut it open and you have to again tent it open, just like, you know, laryngotracheal reconstruction. You have to tent it open by putting a, you know, you have to either put a stent or you have to put something in that place, or a laryngeal keel, okay, which is a structure that separates the anterior commissure and allows the wound to heal without forming a web again, right? So you have to apply mitomycin C and you have to laserize, or you can, you know, you can reconstruct it by opening it, open reconstruction, and you have to put something to stent it open. And some of the children, they need tracheostomy also, because the web is very thick and cannot be dealt with. Then your patient may need a tracheostomy to allow for growth before elective repair can be done, especially thick webs. So you can see a thin web here, okay? So you can see a thin web here, anterior commissure. In this picture, you can see the thin web. You can see the thin web here, anterior commissure. And what treatment is laserization with mitomycin C application. Remember, mitomycin has many uses in endolaryngeal surgeries. So patent acquired bilateral vocal fold paralysis. Another cause of avibular stridor is acquired bilateral vocal fold paralysis, vocal cord paralysis. So how do you get vocal cord paralysis? Could be congenital because of stretching of the neck. So especially common after children who are born after a forceps delivery, because in forceps delivery they stretch the neck. So due to stretching of the neck, there can be congenital bilateral vocal fold paralysis, vocal cord paralysis. And another cause of acquired vocal cord paralysis is patent ductus arteriosus, because when you are ligating the patent ductus arteriosus, you can injure the recurrent laryngeal nerve. And cardiac surgery, esophageal surgery, and thyroid surgery in newborn or young children is the cause of acquired bilateral vocal fold paralysis. So if bilateral vocal cord is paralyzed and the vocal cords are completely adducted, tracheostomy is indicated. You may try with intubation with CPAP, or you can try with high flow nasal cannula. Most of the time they will need tracheostomy. So what is the pathogenesis of bilateral vocal fold paralysis? What do I mean by vocal fold paralysis? I mean paralysis of the abductors, because there is only one abductor and all the adductors. So vocal cord will get adducted. Vocal cord will get adducted. If both vocal cords get adducted, what will happen? Both vocal cord get adducted, what will happen? Naturally, there will be, child will not be able to breathe. The airway will be compromised and the child will be in stridor. That's why we are discussing it here, right? Bilateral vocal cord paralysis or vocal fold paralysis. So what does it present? Present child may have aphonia, high pitch biphasic stridor, and the child may also have, जैसे उसमें velocardiofacial syndrome था, laryngeal web में, इसमें है Arnold-Chiari malformations, Arnold-Chiari malformation, cranial malformation, brain malformations, and increased intracranial pressure. This may be linked with congenital vocal cord paralysis. So what are the options? Open laryngoplasty with posterior cricoid graft, okay? Or if the vocal cords are both adducted, what you can do? You can punch a hole in the vocal cord, what's called cordectomy. Basically, vocal cord दोनों adduct हो गए, उसमें छेद कर दिया, तो cordectomy हो गया, ठीक है? हवा नहीं जा रही है, vocal cord adduct हो गया है, हवा कैसे जाएगी airway के अंदर? So you can put a hole in the, we can cut open hole in the vocal cords itself, what's called a cordectomy. So you can do unilateral cordectomy, one vocal cord में छेद कर सकते हो. You can do bilateral cordectomy depending on the airway, right? Depending on how much airway you want, how much the adduction is there, how much is the gap between the vocal cords. You can do unilateral cordectomy, you can do bilateral cordectomy, you can do bilateral open laryngoplasty, and child can have a temporary tracheostomy, and most of the children will spontaneously recover during the first year of life. So bilateral vocal cord paralysis, right? Bilateral vocal cord paralysis. This is what looks like. Vocal cord is adducted, and vocal cord is completely adducted, and you can see that there is no glottic chink. And inspiration and expiration. During the inspiration, there is little abduction. Expiration to completely adducted, so the child will be in stridor. This is what it looks like. Both vocal cords are completely adducted. Now, one interesting thing that I wanted to show you is that in unilateral, it actually happens in bilateral also, but because it's bilateral, it is not seen. What happens is that the arytenoid cartilage now it falls forward. Lesser remembered phenomena is that arytenoid cartilage falls forward. So in vocal cord paralysis, the arytenoid cartilage will be at a lower level because it falls forward because of anterior medial tilt of the arytenoid cartilage because of the paralysis of the recurrent laryngeal nerve and the loss of tension of the vocal cords. The arytenoid cartilage undergoes an anterior medial tilt. So this picture shows you the anterior medial tilt. You can see the left-sided vocal cord is paralyzed and the vocal cord itself is at a lower level. You see, it is no longer tension. So it is at a lower level and the arytenoid has got anterior medial tilt. And this is exacerbated by respiration. This is less known fact, less understood fact that loss of tension of the vocal cord causes the anterior medial tilt of the arytenoid cartilage. This is seen on both sides, so you will not appreciate that on bilateral vocal cord paralysis, but definitely in unilateral vocal cord paralysis, you will see that the arytenoid has got an anterior medial tilt, and this is increased by the respiratory efforts of the patient. So this is again unilateral. You can see the arytenoid tilt here very nicely, and always the paralyzed vocal cord will be at a lower level than the normal vocal cord. Please remember this. The paralyzed vocal cord will be at a lower level, and the normal vocal cord will continue to move and compensate for the paralyzed vocal cord. So the patient may have a normal voice in unilateral vocal cord paralysis, and the patient will not be in stridor. So that is that. I already told you the treatment part of it: cornectomy and open laryngeal surgery. Continuing on, next treatment, next disease we are going to discuss about afebrile stridor is subglottic hemangioma. Subglottic hemangioma is a vascular malformation that affects the subglottic region. There are two phases of subglottic hemangioma. As a postgraduate in ENT, you should know these two phases: a proliferative phase and a regressive phase. In proliferative phase, it grows from 3 to 6 months of life and starts to regress by 1 year to 1.5 years of age. So proliferative phase only it will manifest. The child may be normal at birth, and at 3 to 6 months of age, the child will develop a stridor. And then always look for cutaneous hemangiomas in the head and neck region. So if you find a cutaneous hemangioma in the head and neck region, the child may also have a subglottic hemangioma. How do you treat? You do microlaryngeal surgery with carbon dioxide laser, and you can of course apply mitomycin C. And there is high risk of subglottic stenosis. Any surgery in the subglottic stenosis, risk of any surgery in the subglottic region, high risk of subglottic stenosis. You can use KTP and thallium lasers. You can use endolaryngeal microdebriders, which are new instrument that has now been added to the armamentarium of microlaryngeal surgeons. And of course, you can apply mitomycin C. Mitomycin C to her case, if I will give you a trick answer, whatever is there, you always write mitomycin C application. You can always apply mitomycin C at the end of the endolaryngeal surgery. So whether it be subglottic hemangioma, whether it be vaporization of the webs, right? Whether it be for subglottic stenosis, you can always apply mitomycin C because that will prevent the fibrosis and that will prevent the subglottic stenosis from happening. So you can see apply mitomycin C, and you can use open surgical resection also. One of the interesting treatment that is being suggested in the PG books is subglottic hemangioma is oral propranolol. Propranolol is also very effective, they are saying, because it is a beta blocker, Indrall or propranolol. So this is a picture of a subglottic hemangioma. You can see a red colored mass below the level of the vocal cords. The child will have expiratory stridor, right? Because it's the subglottic region. And you can see the reddish mass. If you see a reddish mass like this, the diagnosis is very obvious in a child. It's subglottic hemangioma. Okay. So intubation granuloma, I already told you intubation granulomas are common over the arytenoid region. So what you do is treatment is nothing but you put a little bit of mitomycin C on the top of it and it will die, or you can laserize it. So intubation granuloma. So when a child after removal of the endotracheal tube develops a stridor, there are only two possibilities. One is intubation granuloma, arytenoid granuloma, or subglottic stenosis. These are the three possibilities of somebody who has been intubated for a long period of time who comes off with a stridor. Rarer possibility is even dislocation of the arytenoid cartilage. So these three common causes are there. One is intubation granuloma. Second is subglottic stenosis, subglottic edema, and then arytenoid granuloma, and even rarely dislocation of the arytenoid cartilage, leading to falling forward of the both vocal cords. Both bilaterally happens only, it becomes more problem. Okay, these are the three causes of airway obstruction after the patient has been extubated. So this is a simple problem. Okay, now comes all this is about afebrile stridor. Now comes the febrile stridor. We are going to talk about febrile stridor from this point onwards. Okay, so these are all causes when the child will have, along with the stridor, they will have fever along with stridor. They will have fever along with the stridor. So these causes the child will have fever. So first cause let me talk about is croup, which is called laryngotracheobronchitis. Croup is a disease seen in children from 6 months to 3 years of age, and seen in children from 6 months to 3 years of age. It's seen in late autumn and winter, and it is associated with parainfluenza virus 1, 2, 3 in 80% of the cases. And influenza virus, enterovirus, even coronavirus can present with croup or laryngotracheobronchitis. And usually it lasts only 3 to 7 days. It's a short period problem, right? It lasts only 3 to 7 days. And the main problem of laryngotracheobronchitis is swelling in the subglottic region. So incubation period is 2 to 6 days. The parainfluenza virus multiplies in the nasopharynx, from where it goes into the larynx and trachea, and then into the vocal cords and the subglottic region. There's a viral prodrome where the child has got fever, running nose, cough, and then it is followed by barking cough, barking seal cough, something like a seal. Like that the sound is made, and the child is coughing all the time, like a seal sound is made, and the child is coughing. And then there is triad of hoarseness, expiratory stridor, and upper airway obstruction. Hoarseness, expiratory stridor, and upper airway obstruction. Think in terms of laryngotracheal bronchitis in a febrile child. Okay, and what are the danger signs in presence of croup? Because croup is nothing to do with the croup, right? You have to manage conservatively. 3 to 7 days, it will go away. Only supportive oxygen, admission in ICU, and treatment has to be given, right? And nebulization has to be given. So what are the danger signs? When you should become serious and when you should think about tracheostomy in a child with a croup? If the stridor is biphasic, if there are chest retractions, if there is cyanosis, if the respiratory rate is very high, and the child's oxygen saturation is desaturating, and very importantly, the child is becoming unconscious. Any stridorous patient who has become unconscious has to think in terms of airway hypoxia, and you have to immediately intervene by doing a tracheostomy. And how do you make a diagnosis of croup? This is how. Take an X-ray, AP view, you will be able to see a subglottic narrowing, what is called steeple sign, right? In subglottic hemangioma, subglottic stenosis also you will get this sign, and in croup also you will get this sign. But here the croup child will have fever also. So immediately you can make a diagnosis. Important thing about child with febrile stridor is that such a child should never be manipulated. You should not put a tongue depressor and try to open the mouth and see, because you don't know, you may precipitate the airway obstruction and the child may die in front of you. The child may precipitate a laryngeal obstruction and the laryngospasm and the child may die. You may precipitate a pulmonary edema and the child may die. You may precipitate a airway edema and the child may die. It's very risky. You cannot put a tongue depressor and see the patient. A child who comes to you with stridor and fever, you should not put a tongue depressor at all. So you may ask me how to examine. So what to do? You have to take a X-ray, AP, and lateral view. If you take an X-ray, AP, lateral view, you can see almost any. You can make a diagnosis 90% of the time. So if you take an AP view, you will see this steeple chase sign. You can immediately make a diagnosis of acute laryngotracheobronchitis. If you take a lateral view, you will see the thumb sign. You can make a diagnosis of acute epiglottitis. So steeple chase sign, like the top of the church steeple, right? Top tip of the church, you can see the narrowing in the subglottic region, what is called steeple chase or steeple sign. So this is what a croup looks like. See how much edema is there. The whole laryngeal structures are all edematous. Treatment, 3 to 5 days spontaneously resolves. Actually, you have to admit the patient, but at the same time, nothing much has to be done. Only spontaneous resolution. You can give steroids, glucocorticoids, and you can give racemic L epinephrine, racemic L adrenaline, right? You can give racemic adrenaline through inhalation. Through this reduces the airway edema and decreases the vascular permeability. You can also give heliox mixture, helium oxygen mixture for breathing, and you can give humidified air. So treatment is only racemic L adrenaline inhalation. Okay, so that's all the treatment. There is no further treatment, only supportive treatment. Continuing on. Again, next condition that I want to talk about is very, very important, even for UG, even for PGs. It's very important condition, frequently asked in Viva, but not very commonly seen in the community, is acute supraglottitis, also called acute epiglottitis. Why it is very important? Because it rapidly leads to progressive airway obstruction, and it may lead to death. Cellulitis of the supraglottic structures, edema, laryngospasm, right? So edema of the epiglottis pushes the epiglottis posteriorly and inferiorly. Okay, so this is also a acute condition. There is high fever, right? And the most common organism that causes is Haemophilus influenza. But now we are giving Haemophilus influenza B vaccine to everybody. This is protective against acute epiglottitis. Earlier it was common in children. Now it is common in school-going children from 6 years to 12 years of age. Other organisms that can cause acute epiglottitis are pneumonia, Streptococcus pneumoniae, pneumococcus, Streptococcus pyogenes, Staph aureus, and other serotypes of H influenza. Even Kawasaki's disease, right, can present like a Haemophilus, can present like acute epiglottitis. There is severe dysphagia, drooling, and respiratory distress. The main difference between ALTB and croup and this one is that here there is dysphagia. Child has sore throat. There the child does not have sore throat. Here there is sore throat. And there is drooling. Child is not able to swallow the saliva because of the swollen epiglottis, right? And the child has got high fever and a very classic sign called tripod sign. Tripod sign is the using of hands to brace against the bed, and the head is held in sniffing position to maximize the airflow. So this is called a tripod sign. There is high risk of laryngospasm and death in these patients. So you should never ever try to examine the oral cavity of such a child. A child is coming to you in stridor and in fever. You should never put a tongue depressor and try to see the mouth. You should immediately order the X-ray, AP, and lateral view like a wise doctor. You should not give. You should give oxygen through prongs. You should give a nebulization, but you should never ever ask try to open the mouth and try to see the tongue or the oral cavity. No information can be gained because you cannot see the epiglottis by putting a tongue depressor in the mouth, right? So the child who will present with a tripod sign, with the hands braced against the bed and held in the sniffing position, right, as if to sniff a rose, the head will be held in an extended state, and this is called tripod sign. And child who has a tripod spine has got an impending airway obstruction. We should not examine such a child. So this is what an acute epiglottitis looks like. You can see the epiglottis is reddish, swollen, and all the supraglottic sign structures are all swollen. You can see the thumb sign. Epiglottis swollen. Epiglottis looks like a thumb on the lateral X-ray of the neck. You can see that there is one more sign called vellicular cutoff sign. See, you can see the vellicula is looking like a box. It has no communication to the lower airway or the larynx. It has become cut off. This is called vellicular cutoff sign. See, the whole vellicula on the left side is looking like a box. And the arrows, see, there is no communication of the vellicula with the larynx or the lungs airway. So this is called vellicular cutoff sign, and the swollen epiglottis is the hallmark for acute epiglottitis. And always child has to be examined in the operation theater because we have to do tracheostomy in the airway obstruction condition. The airway is secured. You have to do a tracheostomy or endotracheal intubation, and the edema will usually subside within 48 to 72 hours. You have to give second and third generation cephalosporins. There is no role of antibiotics. Here you have to give antibiotics because it's a bacterial infection, and it takes a little longer, 7 to 10 days for the problem to subside, right? So you have to be very sensitive towards diagnosis of acute epiglottitis. Another less common condition, I have seen only one patient of this, is that acute exudative bacterial tracheitis. This is exactly like acute epiglottitis, only thing the whole trachea is inflamed by Staphylococcus aureus, Moraxella catarrhalis, and Streptococcus pneumoniae and Haemophilus influenza. It is usually seen in the 8 years of age. It is seen in winter. I already told you all respiratory infections are common in winter. There is mucosal ulceration. There is no mucosal ulceration. It's only edema. Here there is mucosal ulceration, and there is pseudomembrane formation, and there is extensive sloughing. That's why it is a very dangerous condition, and the child may die of bacterial tracheitis. Actually, my patient, which I had seen many years back, died of bacterial tracheitis. When we did tracheostomy, full of membrane. When you put the incision, looked into the trachea, there was full of membranes inside the trachea. There were thousands of membranes sticking out in the mucosa because of mucosal necrosis. And the child presents with very high fever, stridor, barking cough, and increasing respiratory distress. So we had to do a tracheostomy for that child because the child was going in for severe respiratory distress and cyanosis, and there was no other way. He was not able to breathe at all. There was loud stridor, and the X-ray was, the AP lateral view was normal. So we had already ruled out acute epiglottitis. So we were almost sure this was a bacterial tracheitis. The child was malnourished also. So we had to do a tracheostomy to save the child's life. When we did tracheostomy, inside the trachea, there was all white membranes, full of membrane, right? Don't forget this, full of membrane. It's like diphtheria of the trachea, full of white membrane. I cannot forget, trachea kholte, andar pura white membrane chipka hua tha. Child was in very bad shape. was having extremely high fever. It's not high fever. Usually, high fever stridor we were thinking in terms of acute epiglottitis, but this one was not acute epiglottitis. Under the OT, we examined the patient. The epiglottis, supraspinatus structures were all normal, and then only we proceeded to tracheostomy. We found out it was full of white membrane, and there was nothing much we can do. We did a tracheostomy. The child lived for 2-3 days, and one night it expired. The child died because this is a very problematic condition to treat, right? And the child was extremely toxic. I cannot forget the appearance of the child. And there was dyspnea, and there is barking cough. And if you take an X-ray, you can see diffuse haziness of the trachea, right? And if you do endoscopy or direct laryngoscopy, you can see that there are membranes inside the trachea. Okay. Few other causes of fever with airway obstruction is pertussis, whooping cough, and infectious bronchiolitis. I'm not going to discuss it today. Okay. How do you treat bacterial tracheitis? You have to do clindamycin or vancomycin, and you have to do frequent saline administration and suctioning via the endotracheal tube or the tracheostomy tube, and you have to keep the endotracheal tube for 6 to 10 days. This is even bigger problem than acute epiglottitis. You have to give 2 weeks course of antibiotics, and pneumonia is also present in many of these children. Usko bhi pneumonia tha, 50% of the children, and hypoxia and death is very common in bacterial tracheitis. Is a very problematic condition, difficult condition to treat. Another cause of febrile stridor, which I'm going to discuss as a final case today, is retropharyngeal abscess. In retropharyngeal abscess, there is suppuration of the retropharyngeal lymph nodes. It's an interesting disease. 6 का आंकड़ा है, 6 महीने से 6 साल तक ही होता है, right? 6 का आंकड़ा याद रखना. Many things in ENT are 6, so 6 महीने से 6 साल तक ही होता है, 6 का आंकड़ा है. And it is usually seen post pharyngotonsillitis, adenoiditis, otitis media, or sinusitis or dental infection. It can also follow a penetrating trauma from a fish bone, right? And the organisms frequently involved are group A beta hemolytic streptococcus, staphylococcus, streptococcus pyogenes. The child will present just like your epiglottitis, fever, sore throat, stridor. One interesting difference between all this is the child will have torticollosis. The child will have spasm of the sternomastoids and will tilt its neck and keep in one position, right? That's called torticollosis, which is due to spasm of the sternomastoid muscle, right? And there is altered voice and neck lymphadenopathy. So again, if you take an X-ray lateral view, immediately you can make a diagnosis of retropharyngeal abscess. The retropharyngeal air shadow will be increased, okay? And increased the air shadow, you may also find that there is a what you call air gas, air gas picture, which shows that there is an abscess in the retropharyngeal region. The antibiotic of choice in this condition is clindamycin because anaerobes are involved, or cifotin, or beta-lactamase resistant penicillin, ticaricillin, clavulanic acid, piperacillin, tazobactam, ampicillin, sulbactam. So remember the drug of choice is clindamycin and metronidazole because it's anaerobic. And you can do a transneedle aspiration. First you aspirate it and confirm the diagnosis. Then you use a transoral drainage using a direct laryngoscope or a tongue depressor using via the sister rose position. Put the child in tonsillectomy position and you drain the abscess. So that concludes my lecture on pediatric stridor. And these are my references. I have liberally consulted all the postgraduate books. The most important book that I think you students and my students should read is Cummins Pediatric Otolaryngology. It's a separate book, very nice book. Much of material that I have covered today is taken from Cummins Pediatric Otolaryngology. These are the other books that I did consult. But I think my recommendation for your reading is Cummins Pediatric Otolaryngology by Lesprance and Flint. Try to get hold of this book and try to read the topics that I presented today. And my presentation also basically from that. I read that book and then made these slides. So I think you also should read those books. It's a recommended reading from today's lecture. So there are many questions from today's lecture. Croup, acute epiglottitis, juvenile onset respiratory papillomatosis, laryngeal webs, congenital subglottic stenosis, which itself is a big question, acute laryngotracheal bronchitis, laryngotracheal reconstruction. So many questions can come from today's lecture. So these are some of the questions that have been asked in the examinations year before. So please read up and revise yourself using this book that I am suggesting. Thank you very much. Thank you very much. And I want to thank the National Board and Navneet sir for giving me this opportunity to present. Thank you very much. Now is the time I take some questions from you, the audience. Yeah. Yeah. Are there any questions by the audience? Hello?
Can you see the chat box?
Just hold on, sir. This interface is and chat with everyone. Hold on, sir. Yeah, I can see there's nothing here. Can you see the chat box, sir? If chat with everyone, huh? Nope. Yeah. Just hold on, sir. Chat with. Chat with. Chat with. I'm saying hello. Yeah. Now I just want to invite the audience to ask any questions that they any doubts they may have. I suppose my chat is visible to everybody. Hello?
Yes, sir. There are a few questions in the chat box, sir.
Just hold on, sir. I'm not able to see those questions. See all that in this
One
chat.
moment, sir.
Chat all panels. Yeah. Adrenaline biotartrase. Everything was explained. Okay, general messages. How to use adrenal nebulization? How long to use, sir? You can use adrenal nebulizations every 2 to 3 hours, and there is nebulization solution available, right? This is not general adrenaline I'm talking about. I'm talking about racemic adrenaline, which is slightly different. And there are preparations that are available that is called L adrenaline. It's not just mixture of adrenaline, because adrenaline is mixed of L and R adrenaline. They are saying you have to give L adrenaline, racemic adrenaline. Okay, and every 2 to 3 hours you have to give a nebulization. There is one ampule. There's no such dose per se. Break the ampule and you give. That's it. What's the role of IV steroids in croup? Yeah, you can give steroids. I already mentioned that you can give steroids, short course of steroids, because it's an edematous condition. So definitely you give steroids, there will be benefit. So there is a role of glucocorticosteroids in treatment of acute epiglottitis. And croup also you can give, because both are edematous condition. But croup there is much less role of steroid, because it's more of a viral infection only. So in acute epiglottitis there is a little bit more use, because edema is more. And croup more of conservative line of management. Even antibiotics are not indicated in croup. Only thing you have to make a correct diagnosis, differential diagnosis of bacterial tracheitis, acute epiglottitis, and croup. You have to differentiate these three conditions. Is there any glycopyrrolate or atropine nebulization decreases secretion? No. These conditions that not much secretions. So there is no role of glycopyrrolate or atropine. As far as I have read, I am practicing. I am not using glycopyrrolate or atropine nebulization at all. Especially in these conditions, there is no role. There is no role. Okay, because it's not increase of secretions; it's edema. So steroids have a role, but this one don't have. And as for adrenaline, you cannot use direct adrenaline. You have to use racemic adrenaline, which is specially prepared for nebulization purposes. Any other questions, sir? Think I have answered all the questions. Is there any more questions? I invite the audience to ask them. Okay, so I suppose I have answered all the questions. So I'm just giving you. I just want to tell that at the end of the day, you have to correctly make a diagnosis of a patient who comes to you with stridor. Always remember, in stridor, you can take an X-ray, AP, and lateral view of the neck, and the X-ray can be taken bedside. You can take it immediately, and that will give you a lot of information in a patient who is having stridor. So don't forget X-ray, anterior, posterior, and lateral view. You have to take AP also, because lateral view loge to you will miss laryngotracheal bronchitis, which is seen only in anterior posterior view. So, and lateral view you will see acute epiglottitis. So please remember, you have to take both AP and lateral view. And any child, any person, not even a child, any person who comes with stridor, instead of examining the patient, you can immediately order an X-ray AP lateral view. That will help you give you a clue what is exactly the problem, right? And any child who suddenly presents with stridor without fever, you always have to rule out foreign body, right? That's the number one differential diagnosis in a child who's not having fever. A child who has fever, number one diagnosis is croup. And a child who doesn't have fever, the number one diagnosis will be foreign body, right? So please remember these 3 points. And if you have any doubts, you can always reach out to me. And thank you very much to
Sir,
the National Board
there
for
are a
giving
few
this opportunity.
questions. Dr. Pooja Mahesh, where
Yes.
you may unmute and ask your question. Dr. Yuvraj, Dr. Monisha.
Yeah. Yeah. I welcome you to ask the question right now. If you have any questions, you can ask me right now.
Dr. Monisha, Dr. Pooja, and Dr. Yuvraj, I have given you the access to unmute and ask questions.
Sir, I think
So I think no questions. Thank you very much, Dr. Santhosh.
no questions. I think. Thank you very much, sir. Thank you very much for giving the opportunity.
Thank you very much, trainees and faculty members, for joining.
Very much for National Board for giving this